Leonard is our fine speaker tonight. He will introduce himself with all of his great accolades, but comes highly recommended if anybody needs anything. He's very, very passionate about what he does, and he's been in this for years, and he's very involved in the community and kids, high schools and sports, and so comes highly recommended. But I will let you take the floor.
Thank you. Welcome, everybody. Thank you for taking time. It's beautiful out. You know, our summer is very narrow. You know, we only have a limited amount of time where it's actually nice outside. So thank you for sacrificing one of those nights to come hear me talk about people. So, you know, I'm going to talk about, you know, shoulder pain. And I titled this, Don't Give Your Pain the Cold Shoulder. And the reason why is that, you know, a lot of the patients that come in are very reluctant to come in. You know, the last thing they want to do is see a surgeon because they don't want to have surgery. And I get that. And, you know, I would say that probably on average, people wait 3 to 6 months before they actually come and see someone for their shoulder pain, because, you know, they'll just assume, it's going to go away or something along those lines will happen. And for the most part, that could be true. But I think oftentimes we end up suffering longer than we really have to because of some of these kind of preconceived notions we have about the shoulder and, you know, what's going to happen in the appointment. So the idea here is to kind of, no matter who you go see, whether it's me, whether it's some of the other, you know, great shoulder surgeons that are in the area, you know, these are some of the commonalities that we have when we, you know, talk to someone. Not working.
No.
Okay, there we go. So thank you to Advocate for, you know, advertising this and sending the word out. I'm appreciative. You know, I've had a relationship with Christ Hospital since I started practice in 2012, but I was a resident back in 2006 when I started working for Advocate as a resident, you know, as a young doctor learning. And so I'm very appreciative of everything that they've done for me throughout my training and into my career. So this is my current practice. I'm in Midwest Orthopedic Consultants. It's the office that's right between Christ and Target now. It used to be an Allstate building for people that are, you know, familiar with Oak Lawn. Right between the B of A and the car dealership. So, you know, we have the whole first floor and Advocate has the whole second floor. We also have an office in Orland Park that's by the ice arena. And my specialization is in shoulder, elbow, and sports medicine. So that's primarily what I take care of, pretty much all shoulder and elbow. And I take care of knees, hips on occasion as well. But, you know, when I started my practice, I was 50% shoulder, elbow, 50% knee, and now I'm probably almost 90% shoulder, elbow. So I actually may end up giving up knee and just focusing on shoulder, elbow because there's just such a need for it. So just a couple other things that I do. You know, I love my sports medicine. I love my coverage. When I was in Nashville, I covered the Predators for the NHL, and I covered Vanderbilt University. James Franklin was the coach. He's now at Penn State. I would run through a wall for that guy. I thought he was awesome. So when I came back, you know, I had the opportunity to either work at Northwestern with the football team or come local. And working for a Division I college football team basically means you're working 7 days a week. And I just had twins. And so it was either do that or have a family. And I ended up having the family. So, so I still do a lot of this. You know, the pictures on the left and the right are me covering football. So I still cover Marist High School. I've been with them for 10 years, and Sandburg, which is my alma mater. I've been there for 11 years. And then I also work with the USA hockey team. So this picture in the middle is me with the Italian medical staff that was helping me when we were in Italy. And actually we were in northern Italy, Chiavenna, in December of 2019. And if people remember, in January of 2020, that's when COVID happened, and it actually started in northern Italy, which is where this was taken. So it's very interesting to see what happened. My family came with me, and my mom came with me. And I sometimes joke around that she brought COVID to the United States, but you know, so but yeah, but it was a great time. We won the gold there in Italy, so it was great. You know, I do other things academically. I work for the University of Illinois, Chicago. I do a lot of work with journals and editorial boards, and I do a lot of research. So I can't sit still just doing one thing. I love my clinical work, but I like to kind of, you know, go to all different types of areas. So today we're going to talk about the shoulder. So this is the number of visits that people come in for musculoskeletal problems. And if you look, shoulder is number 3. So 11 million visits in 2010. And that number just continues to go up. So knee is the most common, followed by the back, but the shoulder is pretty common. You it affects about 1/4 of the population, and it's anything from trauma to athletic activities to just everyday activities. I think, the most common thing I hear when patients come on and they drive themselves crazy, think, "Doc, I don't know what I did. I'm trying to think about what I did and I can't think of anything." Most people didn't have an injury. It just comes from wear and tear and using your arms and normal everyday activities. And about 2/3 of these are rotator cuff problems. And sometimes the rotator cuff, people get freaked out because they hear about surgery. They've probably had someone who's had a bad experience with a rotator cuff repair. And that's, again, where we start getting into this trepidation about coming in. But about 7 million patients in 2010 had some sort of rotator cuff disease. I could promise you we're not doing 7 million rotator cuff repairs a year. It's just not happening. So most of the common complaints in the shoulder is typically pain in the front and along the upper arm. And I'll even have patients that'll say, "Dr. Leonard, my shoulder doesn't even hurt right here in my arm." But that still is coming from the shoulder. So anything in the front going down to the elbow is considered to be a shoulder problem. And that's a little bit different from, pain that goes up into the neck and going back down. That tends to be more neck. But me and my spine partner, we will argue whether or not this is a shoulder problem causing neck pain or a neck problem causing shoulder pain. And sometimes we don't know. And part of the treatment is trying to figure out, is this neck, is this shoulder? Usually it ends up being both, but we try to figure out what's the best route to treat this. They'll be aggravated with activity. So anything overhead, any sort of reaching, any sort of lifting causes pain. They'll have difficulties reaching behind their back, so tucking in a shirt or snapping a bra strap. But most common thing, and the thing that brings people to me the most, is pain at night. They can't sleep. And if you can't sleep, you're miserable at night, and then you're miserable during the day. So you're just miserable. And that's usually what ends up bringing people to see me. They'll also complain of stiffness and weakness, but that tends to be the order. Again, we talked about the causes: trauma, athletic activities, and everyday activities. People think about trauma, but it's actually the least common. So only 5 to 10%. So falls off bikes, falls onto the shoulder. You think about any sort of injury where there's a fall downstairs is a common thing. But this is relatively insignificant, only 5 to 10%. Or they'll say, "Well, Dr. Leonard, I wasn't a baseball player. I don't do any throwing. How could I have rotator cuff disease?" And this is even smaller. Everyday activities is the most common reason for rotator cuff problems or for shoulder problems in general. Anything that's repetitive. So lots of jobs. I see lots of painters, carpenters, construction workers, heavy labor, but even normal activities. So in the fall, I'll see the rakers. In the winter, I'll see the people that are shoveling the snow. In the spring, it's the spring cleaning. And then it's the summer, it's just from trying to do as much as we can in the nice weather that we have. So it can be any normal type of activity that we do that involves repetitive use. So the next thing then is this kind of potpourri of, well, if I have shoulder pain, well, what do I have? Maybe I have arthritis. And unfortunately, a lot of primaries will just say, well, you probably have arthritis, but that's a significant term. That means you're not getting better. If you have arthritis, you have that forever. And so utilizing the term arthritis is actually something very specific that you can't get unless you have an x-ray. So if you haven't had an x-ray, someone tells you you have arthritis, probably not the right thing. Or maybe I have a tear. Well, maybe I have a rotator cuff tear. That's always the concern. So first it's, do I have arthritis? The second one is, do I have a tear? Am I going to need surgery? But then what about this term impingement? That's a term. Maybe I have bursitis. Maybe I have tendonitis. And unfortunately, people use all these terms to mean the same thing. Oftentimes, this just means that I have shoulder pain, and we use these terms interchangeably, but each of them is very significant in how we treat this. So that's what we're going to kind of figure out. So the shoulder is the most mobile joint in the body. It moves a lot. It moves more than any other joint. And it's composed of your arm bone, which is your humerus, your shoulder blade, which is your scapula, and then your collarbone, which is your clavicle. Also, all three of those bones come in. Please, go ahead, take a picture. Yeah. So all three of these bones make up the shoulder. But the thing is that because of how mobile it is, it's also can have a lot of different problems occur to it. It's a ball and socket joint, so it allows for elevation, abduction, and rotation. So a lot of mobility. And that's why it's such a highly functional joint. And this is why we do all these activities with the shoulder. Now there's a term rotator cuff. Now the rotator cuff is a group of 4 muscles that actually surrounds the shoulder. Okay. And this is what helps us to move our arms. So any sort of movements, any sort of strength with the arm involves using the rotator cuff. And so here's a picture of it right here. And so the red is the muscle. And so people ask me, well, is this a muscle problem or is this a tendon problem? Well, it's really the same thing. The The red is the muscle, and then the muscle becomes tendon, and the tendon is what actually attaches to the bone, and that's what actually causes the arm to move. So the rotator cuff is a cuff. It surrounds the whole ball and socket joint so that it can move in any which direction using a certain portion of it. And then that little white structure that you see here, that's your biceps tendon right up in here, right down there. So that's your biceps tendon going into your shoulder. So that's also why we can get pain is from the biceps. The bursa is that green structure that separates the bones. That allows things to move nice and smooth. So it sits between the ball right on top of the rotator cuff, and that's the bursa. And that again allows for free, friction-free movements. So we're going to talk about here is most shoulder pain is not due to arthritis, okay? This is different from knees, where mostly the time it is arthritis. This is different from hips. Most people that come in, I get an x-ray, they've been told they have arthritis, and then I show them this x-ray. And again, if you look at this, nice ball, good socket, just like we saw with that picture there. This is what both x-rays look like that I see that people come in with shoulder pain. So we have to rule out arthritis. And we'll show you a picture what that looks like in a second. So the rotator cuff is the most common source of pain. And so the rotator cuff can be tendinitis. And so tendinitis just means that the tendon is inflamed. It's, if I rub something enough, it's going to get warm. If I overuse a tendon, it's going to get inflamed. And so that's what rotator cuff tendinitis is. It's just irritated, it's red, it's angry, it's inflamed. And that usually happens when you're doing repetitive types of activities. This is the most common thing that I see is tendinitis, okay? And then that's different from bursitis, which is inflammation of the bursa. So instead of having that nice fluid-filled sac, I think about like having like a bag of potato chips in your shoulder. It crunches, it goes click, 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 it causes pain. And this is, again, another inflammatory process, something that doesn't need surgery. And this is the second most common thing that we see in the shoulder. So rotator cuff disease, the most common, but these are the two most common problems of the shoulder. Don't need surgery, usually can be treated by treating the inflammation. And then tears. So the tear is when the white portion, again, that tendon, starts to come off the bone, okay? And they can be partial thickness tears where it's only partly torn, or full thickness where it's pulled completely off the bone. But some people kind of have trouble thinking about this. So the analogy I use, it's like having jeans, right? If you wear your jeans long enough, you'll start to get a little bit of fraying. That's partial thickness tears. Usually we don't really treat that, right? We don't sew fraying, we just let it be. You could still wear them, they're still good pants. When they get holes in them, that's when we have a problem. It's a full thickness tear. And, and so normally we would sew these unless you're my kids and for whatever reason they buy new jeans that have holes in them. I don't understand that. But normally when we have holes, we want to sew that up. And so that's what a full thickness tear is. And then the final one here is rotator cuff arthropathy. This is the most severe form. And so this is what happens if we wait too long with rotator cuff tears. Is if we wait too long with rotator cuff tears, and this tends to be more common in females by a lot, and patients older than 70, they lose that ability. And so the x-ray on the right, that's the normal x-ray, becomes that. So see the difference now. Now you don't have that nice space. You have bones rubbing up against each other from left to right as well as up and down. So that's rotator cuff arthropathy. That's arthritis due to having a rotator cuff problem. And so when I look at this, we go from tendinitis and bursitis, which again, we can easily treat inflammation to a partial tear, which is fraying, to a hole, to arthritis. And so this is kind of the spectrum, but a better way of looking at it is this way here. So if you look on the left, these are things where pain isn't too bad, weakness isn't too bad, but look at this, conservative non-operative treatment, very effective, okay? So the high majority of people who come in can be treated with conservative non-operative treatment. And if at the very worst, arthroscopic treatment, so poke holes. So notice that for open treatment, there's really nothing we need to do unless we get to the very far right. And that's when we start talking about things like shoulder replacements. But if you look at arthroscopic treatment, very effective, very effective, very effective. We don't even do open treatment for rotator cuffs anymore. It's not necessary. So even in the worst cases, we can treat this by using a camera rather than making a big incision. All right, any questions? No one wants to hear me talk for an hour straight. Any questions? Or we can just go through questions when we're done. But this is kind of brings up rotator cuff. Go ahead.
So how could we prevent having this? Because I had twice already.
Yeah.
and had a little rotation by under the anesthesia and all. But when can we know that now I need to stop before it gets bad?
So here's the thing about that is that, and this is not to sound kind of like morbid or like pessimistic, but most rotator cuff tears we can't prevent. You can't prevent it. A lot of it is genetic and a lot of it is just based on what we do, right? I can't tell a carpenter stop working, right? Doesn't make sense. I can't tell a plumber stop working. I can't tell people around the house, stop cleaning up your house, stop using your arms. The best thing that we can do for this is control the inflammation and keep our motion and strength as high as we can. Because when we start talking about treatment, just because you have a tear doesn't even necessarily mean that you have to have surgery at all. And actually a majority of tears are walking around, don't even know they have the tear. And that's the challenge with rotator cuff disease, is that even having a tear, if I took patients that were 60 years of age and older, about half of them would have a rotator cuff tear with absolutely no symptoms. And so it's not just the rotator cuff problem, it's other things. And so it's about treating the inflammation. If you're stiff, treating the stiffness. If you're weak, making you stronger. And those are the things that actually will keep the symptoms down and then prevent it from getting to, so it's just getting the right treatment at the right time, essentially.
Does the stress have to do anything with this?
I think it does, because it puts the shoulder and the neck are really involved. And so when you have stress, you tend to get tightness in the muscles. Tightness of the muscles leads to decreased mobility. And then again, we go back to the shoulder being the most mobile joint in the body. It does not like stiff. I think every time I see someone who has a shoulder problem, they're going to have stiffness somewhere. They just are, because they're too highly correlated with each other. So,
So what is the treatment for?
we're going to get to it. So just the other thing here, if you look on the left, again, that's our beautiful looking x-ray there on the left. Look at the right. Now there's no space between the ball and the socket. They're almost like one bone. So imagine if that ball is trying to move, grind, crunch, crunch, crunch. Now, in something like this is a lot different. If I had the picture on the left, that's someone who I could give exercises to, get the arm moving, they're going to do really well. If I take the same person on the right, send them to therapy, I'm just going to grind their shoulder. They're going to have more pain with therapy. They're going to be mad at me because why did this doctor, he doesn't know what he's doing. He sent me to therapy and I have arthritis. This is terrible. And there's oftentimes where I'll see patients for a second opinion that were like, yeah, I went to therapy and I got worse. Well, did they get an x-ray? No, they didn't get an x-ray. And they saw, look, arthritis. And so, oftentimes people will come in with MRIs and they'll be, man, Dr. Leonard, I don't need an x-ray. I have an MRI. Well, the MRI isn't necessarily going to show what the problem is sometimes. So that's the difference. Wear and tear, so shoulder arthritis, again, wear and tear. This tends to be males and females are the same. And again, this is where you get more rubbing. This is what we refer to as osteoarthritis. This is wear and tear arthritis. This is a little bit different than rheumatoid or things along those lines. All right, so the question is, when should I see a doctor for shoulder pain? So the 4 things I thought about is traumatic. If you did have a fall, if you did feel a pop and have an injury, that's usually somewhere where you should be seen. If you've been having pain for more than 3 weeks, that tends to be the cutoff for me. 3 weeks, 4 weeks. If you're still having pain after that and it hasn't gone away, generally there's more that can be done for it. If the pain is getting worse, if you feel like you had pain and over time it's just getting worse and worse, that's something. Or if you have true weakness, meaning you can't lift anything. So increased pain, more than 3 weeks, worsening pain, worsening function, that's usually a sign to be seen. Reasons people don't go to the doctor. So I like these. So they think the pain will go away on its own. And again, I think that's totally fair. And I think most things do, right? If we went to the doctor every time we had pain, we'd be there all the time. So that's why 3 to 4 weeks, I think, seems to be pretty reasonable. They don't want surgery. I don't want surgery either. But when I look at, I looked at my numbers. So I see on average about 250 new patients a month. Of those, I schedule about 40 to 50 surgeries a month. So that's 1 in 5. It's about 20%. Okay. So that means 80% of patients that come in, have never seen me before, and I'm not recommending surgery for them. Okay. So a minority of patients actually need surgery. They don't want to be shut down, meaning they can't miss work. They have sports, and I have a lot of athletes that come in, they don't want to see me because they're afraid I'm going to take them out of practice or take them out of sports. And I can tell you, As a sports medicine doctor, if every athlete I saw, I took out of sport, I wouldn't be a sports medicine doctor anymore because the coaches wouldn't send people my way. So it just because you're seeing me, my goal is to get you back at work or get you back doing sports or get you back being active. It's not to take them away, it's to do things to help them go back. So discussion. So, normally a clinical evaluation involves the symptoms and the medical history. And unfortunately, the shoulder is actually relatively simple. And I was taught this back at Vanderbilt is that if I took every patient's age, gender, and their complaint, I could probably get your diagnosis about 95% of the time without doing anything. Just because, again, we talk about rotator cuff, arthritis, age, gender, I could probably tell you what you have. The physical exam I do to see, well, how can I help you? What exercises can I give you? Do you need therapy? What are some things that I can do? And so really the physical exam for me isn't really to determine the diagnosis, it's to see, well, where are the problems? Where are you stiff? Where are you weak? Where is there pain? So that I can figure out a treatment plan. And then I usually get an x-ray of the shoulder again, because if someone has arthritis, I'm probably not going to do therapy. If they have a fracture, that changes things even more. So that's the normal clinical evaluation. MRI should only be given in terms of needing surgery. Okay. And this kind of drives me crazy because, a lot of patients come in, their primaries aren't really sure what to do. So they just order an MRI. And then they read the report that someone else, the radiologist, who's probably in their basement in shorts and a t-shirt, who know nothing about the patients that they're reading the MRI on. And it's like this long, there's usually like 30 to 40 lines of information. And you get a phone call about, yes, you have this. And then patients are freaked out. And the problem with that is they get so freaked out, they don't come see me because they think they need surgery because they have this long list of problems. So really an MRI is a surgical planning tool. Okay. Like I said before, I shouldn't need an MRI to come up with a diagnosis. This is a surgical planning tool. So I only do it if I'm suspicious of an acute tear, meaning you had a bad fall and you have a lot of pain, you have significant weakness, or you've already failed conservative treatment. It is not a first line for anything. And what I'm looking for is I'm looking for a tear. So that bright white space right there, let me go over here. So this is the rotator cuff. This is a hole, and this should be attached here. So this is the tear, again, where the tendon has ripped off the bone. That's a tear. And so that's what I'm looking for. But I'm looking for other things too, tendinitis, bursitis, other things that can be causing pain. So what are the goals of treatment? So number one goal, get rid of your pain. Number two goal, get your motion and strength back to where it needs to be. And then number three is get you back doing whatever activities you want to be able to do. And so there's lots of different things that we can do for this, modify activities, pain medicines, therapies, injections, surgeries being the last ditch effort. So again, decrease pain and inflammation. So rest and activity modification, ice, NSAIDs, steroid injections. This works about 80 to 90% of the time, just doing this, because again, a lot of this is inflammation. So something as simple as taking Advil and ice, and then if that doesn't work, I usually will add a cortisone injection to that, is actually super helpful. Now, let's see, do I have that? Yeah, let's talk about that, because steroid injection is also another kind of four-letter word. People freak out about steroid. I think the thing to realize is that this is not a magic pill, okay? It does not make everybody's pain go away for good, and it's not, but what it does do is it gives you a certain amount of relief. It's basically like cleaning off a chalkboard. It gets rid of all the inflammation, gets rid of all of your pain. That allows the second part of treatment, which is either exercises or therapy, to get motion back, and that's what keeps the pain gone long-term. And the reason why, you hear about people getting multiple cortisone injections, that's usually for people that have arthritis, okay? Because their next step, unfortunately, is usually some sort of replacement. But for rotator cuff disease, you usually only should do one at a second two, because cortisone actually weakens the rotator cuff. So you have to be real careful about multiple cortisone injections, one, maybe two, but if you keep getting them, you're actually making that rotator cuff weaker, and that's what pushes people to that rotator cuff arthropathy, where now we're talking about big major surgery. And so we have to use this judiciously, okay? Physical therapy can be either a home exercise program. It does not have to be formal PT. One of the good things about that happened from COVID is that we started developing home exercises because people were nervous about going to formal PT. And what we found is that the home exercises work just as well as going to formal PT. Sometimes patients need that extra help, but not all the time. And the idea is, we go back to the physical examination. If, oh, I saw that you were stiff on exam, I'm going to tell therapy, work on so-and-so's motion, make sure they can get their arm all the way up, make sure they can reach their back. Most shoulder pain, again, is due to lack of mobility. So getting mobility back is probably the most important thing, secondary to getting rid of your pain, and then increasing strength. Weakness leads to tendonitis, weakness leads to tearing. So again, we talk about prevention. We want to keep mobility, we want to keep strength. When I was at Vanderbilt, I was part of what's called the Moon Shoulder Program. So all these big academic institutions from all over the country did a research study on rotator cuff tears. So they took 400 patients that had rotator cuff tears, and they wanted to see how many of them would get better with physical therapy. And the interesting thing is that this study was funded by a company that actually gives the implants for surgery. And what we found is that 85% of patients with full thickness rotator cuff tears got better with therapy plus an injection, 85% up to 5 years. So that's where, and that's why I kind of got away from, people hear they got rotator cuff tears, they think, oh, I need surgery. Usually I have to talk them down and say, no, you don't need surgery. 85% of you guys are going to get better with the right therapy. And so that's where just having a tear doesn't necessarily mean anyone needs surgery. About 15% actually end up needing surgery. Surgical indications, a traumatic tear, again, significant weakness, and then failure of 6 to 12 weeks non-opportune. Just the same reason why we would get an MRI. The goals of surgery, again, reduce shoulder pain, improve strength, and allow return to all activities, regardless of what that may be, whether it's athletic, whether it's just home activities, going back to work, whatever. Most surgeries nowadays are done with a camera. So the camera is about the size of a pencil. You go inside, you look inside the shoulder, and it has the same results as open surgery, but less pain, quicker recovery, and smaller scars. I don't do any shoulder surgery at a hospital anymore. Everything is outpatient. Even shoulder replacements now are being done as an outpatient. So there is no longer a hospital stay for any of these procedures. It's not necessary anymore. Even a shoulder replacement only takes about an hour to an hour and 15 minutes. No reason to spend time at a hospital. I tell my patients the hospital is where sick people go. Okay, you're not going because you're sick. You're going because you have this problem that we can treat with this minimally invasive surgery. So on the bottom right, this is actually one of my surgeries. And so this is me looking around inside the shoulder. And then I'm taking another device that's about the size of a pencil, and it's just a little shaver, and it's just eating some of the sick tendon that's causing some of the pain. So I'm just going in there with this device, and I'm just cleaning up some of the rotator cuff that's partially torn, cleaning up some of the inflammation, and looking around at all the other tissues that I'm seeing here. So that's what we're going to do inside the joint here. And so a lot of times when it's just inflammation, I can go inside the shoulder with this device and just really clean up the pain generators, leave the good tissue alone, and then we're done. And so this is me kind of looking around and cleaning up anything that doesn't look healthy, anything that's red, anything that looks like it might be causing pain. And we can do that pretty readily. And typically when we do a cleanup surgery like this, it's usually about 4 to 8 weeks of PT, 2 to 4 months for full recovery, but people can get moving right away. Again, the rotator cuff is on the bottom. I'm just cleaning up some of the bursa right now. Now it's a little bit different if it's a rotator cuff tear. So again, this picture on the left is showing the white, again, is the tendon. The bottom portion, the yellow, that's the bone. That's where the tendon is supposed to be. So that's a rotator cuff tear. So what we're going to do is we're going to sew it back together. We're going to make it look like that. So that's showing the rotator cuff being sewed back down to the bone so that it can heal back. So we're literally just taking plastic screws that have stitches and sewing things back together through the camera. And that's the idea. Now, this surgery itself is actually pretty easy. Again, it's done through the camera, it's outpatient, it takes about an hour to do. The problem is that rotator cuff repairs take a long time. And I think sometimes if you underestimate the length of the recovery, that's where people get frustrated because they're 3 months out, they think they should be better. And I'm like, nah, not really. How I break it up is I break it up into thirds. So the first 6 weeks is about getting the rotator cuff to heal. The second 6 weeks is about getting your mobility back. The third 6 weeks is about getting your strength back. So that's 18 weeks. That's 4 or 5 months-ish to recover and up to a year to feel close to normal. Okay. So it's not a painful recovery. It shouldn't be. Patients yell at me because of the sling I make them wear, but that's okay, I can take it. But usually it's not the pain, it's just the time. And so I spend more time talking to patients about the recovery than the surgery. They're asleep during the surgery. They don't care what I do as long as I do a good job, but this affects people's lives. This affects their ability to go to work and how they set up. Do they need help at home? And so we spend more time talking about the recovery than we actually do the actual surgery. In terms of results, most patients get improved motion and strength. The majority of patients return to their normal everyday activities. That is the expectation now. It's no longer to get a little bit better, to get a little bit of strength back. It's to get back to doing everything that you were doing before you started having pain. That's the expectation in the 21st century. In terms of arthroplasty, unfortunately, if we get to the point where now we're talking about bone on bone, now we're talking about doing something that's a little bit more aggressive. So this is where we're actually talking about getting rid of the arthritis and putting in a new shoulder. Now, shoulder arthroplasty sometimes freaks people out because everybody knows someone that's had a knee replacement, right? About 55% of all replacements are knee. Most people know someone that's had a hip replacement. That's about 30%. Not a lot of people know about shoulder arthroplasty. It's only about 7% of all the arthroplasties done. It's just not as common because most of us don't walk on our arms. And so we don't develop arthritis in the shoulder as quickly as we do in our knee and our hip. But so oftentimes people will be like, Dr. Leonard, is this experimental? And like, no, this has been around for a long time. And it's becoming more and more prevalent. They say that shoulder arthroplasty surgery is going to go up 400% in the next 20 years, just because of how much we're using our arms and how much we're able to help patients with this. And so the two ones we have is one is just arthroplasty, where we just put in a metal ball. And then the other one is the reverse. This is actually the most common one. And this is what we use for people that have rotator cuff tears and arthritis, which is most people. And so I'd say about 80 to 90% of my practice is now doing reverse shoulder placements. And we do about 150 of these a year. It's probably the most on the south side. You probably have to go to the city to find someone that does more, but this is much more prevalent. My father actually just had one last Tuesday. So I've gotten calls from him every day about that. So I treated him, but I would not do the replacement. So, so the question really then becomes, and this is for any surgery. I think I put this for replacement, but I think this is unfair because this works for rotator cuff repairs or any surgery that you go through. No one ever has to have shoulder surgery for anything ever, right? No one, anyone can live with what they have. I give the information, but it's up to the patient to decide if it's the right thing for them to do. And it's got to work for you. It's got to work for your family. It's got to work with your primary doctor and your surgeon. You all have to come together and make sure that this is the right thing for you. But again, surgical indications is pain that prevents you from doing everyday activities, pain at rest, and then pain severe enough to prevent a good night's sleep. I think those are some of the key things that I look at, but everyone's a little bit different. Everybody's criteria for having surgery is different. So I lay it out for them. If they don't want surgery, we will continue to treat them for as long as they need to until they say, I will never tell someone you have to have surgery. They're going to tell me, Dr. Leonard, I'm ready to have surgery. This is not graphic at all, but basically what we do with this is, there's the arthritic shoulder. We just cut off the ball that's arthritic, and then we just put a ball, and then we smooth out the socket there. And then we're going to put in, and actually, this is old. We actually don't even use stems anymore. We just take a ball that's the same size as what we cut off. We just put it on. So we're no longer using stems anymore in the shoulder. So if you just take the ball, I just go plop and I put it on, and then I put that socket in place and we're done. So we're not using stems anymore. It makes the surgery less aggressive. Again, the surgery takes about an hour to do. And I would say about 80% of my patients go home the same day. Another 20% aren't comfortable. They want to spend the night. They spend the night. They go home the next day and they're done. Expectations. Generally, about 90-95% of patients get complete pain relief in as quickly as 2 weeks. This surgery is awesome at getting rid of pain, okay? The only difference is motion and strength, and that's dependent on the person in terms of how much they're willing to work for it, because for some people who've had arthritis for 10, 20 years, they haven't used their muscles in that long, and so it takes them a lot longer. So their pain will be gone, but it may take them more time to get their motion, strength, or function back. But I used to do about 18 weeks of therapy for arthroplasties. I'm down now to 4 to 10 weeks. So this is, although it's more surgery than a rotator cuff, it's actually less rehab. Because once it's in, you're done. You don't have to worry or wait for anything to heal. You know, you're in the sling just for comforts. And we start moving it right away. This is showing one of my patients here. This is his surgery on the left here. So you can see on his left arm here, he can only lift it up to not even the shoulder level. His arthritis is pretty bad. We put the reverse in, and not only to get pain relief, but now he can lift his arm up. So we treated both the rotator cuff tear as well as the arthritis with this. So again, a great surgery for him. It helped him out. He got all of his function back and has no pain and is very happy. So, just to kind of summarize this, and I'll take all your guys' questions. Again, most shoulder pain, repetitive overhead activities performed on a daily basis. It's not from trauma. It's not from being an athlete. It's from normal activities that we do every day. Most pain, 80 to 90% of patients will get better with anti-inflammatories, cortisones, therapy, whether that be formal therapy or home exercises, and we'll be able to get improvement in their pain and functional level. And then most surgery nowadays is done arthroscopic, although there are some, again, joint replacement procedures for patients that are pretty far off, both are which are doing fantastically. So this is a picture of me. This will never happen ever again. This is when I was with the USA hockey team in Russia in 2015. Obviously, it wouldn't be any time sooner. And actually, the interesting about this is that I brought a lot of the pain medicines from home for the athletes. And if I started thinking about, I could have been considered a drug dealer, and if it was later on, I may never come back. So I found that to be real scary. So, but this is actually in the middle of Siberia. So you can see there's not much, there's a little town there, and then there's literally nothing. So, all right. Questions? What questions do people have? Yes, please.
How is the ball fastened on if you don't use a?
Yeah, so we use a little almost like flower kind of stem that's grit blasted, so it's very rough. So that goes into the bone, and then the bone heals to it, and then the ball goes right on top of it. Yes.
I had rotator tear 25 years ago or more.
Yeah.
And I seen a doctor who recommended I have surgery.
Mhm.
And I was told by my family doctor, I should get a second opinion to make sure.
Sure.
I got the second opinion. The second opinion was a little different than the first, whereas in the second one, the first fellow, all I would do is operate, not too much explanation.
Yeah.
The second one got to talking and said, well, how does it affect your everyday way of life? What's the changes in your life because of your shoulder? At the time, I was playing a lot of tennis.
Yeah.
Okay. I told him I can't play tennis anymore. And I was doing physical work. And it doesn't stop from working every day. But I can't, throw overhand, or I can't play
And then you
tennis.
can't play tennis, yeah.
So I decided that for me, I wouldn't get the operation.
Hmm.
And for, I'd say about 6 months period of time, I had a lot of pain in my shoulder, especially when I slept, because I sleep on the right side. And over a period of time, it kind of went away. Then it'd come every now and then, so I was saying to myself, weather, arthritis. But this time, I'll be 79, so when I turned 78, I started having the shoulder pain.
Yeah.
I always knew the shoulder was there. But that was okay. Then, after a week or so ago, I started getting on my left side, just
Just the
not
arm
the
pain.
top here, like I did on the right. More so, the pain would be more aggravating on the right than the left.
Yeah.
But what I was about, I'm getting it somewhat on the left now. And I know I had the tear here.
Mhm.
So based on what you're saying, what could be the issue with the left? I know I got the tear here, and the combination of both probably all of them. How come all of a sudden the left is?
Well, here's the
It's
thing.
come from here down to here.
Yeah.
But it will go with the arm, then it'll go down my arm, and I'll get something like a numbness or something.
Mhm.
And every now and then, I have my thumb, I think very seldom.
So you have 4 different problems right now.
Okay.
Number
That's
one,
enough.
yeah, exactly. So number one
Yeah.
is, again, if I just think about, your age 79, there's a 60 to 70% chance that you have a rotator cuff tear on the left side. That's just been sitting there dormant. But now, because your right side has been painful for how long it's been, you've probably overused your left side without even realizing it, just to get by. And eventually that just led to pain. So there probably is a small tear in your left side. Why do I know that? Because it's probably more in here, in the arm. That tends to be more
I
rotator
was
cuff
just gonna
disease.
say, I do not get anything on the top.
Yeah.
In my left arm.
Yeah.
I do, of course, get it on the
Yeah.
right.
So
I get it here.
yeah, so that's more rotator cuff. My guess is on the right side, yes, you have a rotator cuff tear, but you're probably starting to develop a little bit of arthritis, which is why you're getting more pain in the shoulder. Now, we talk about shoulder and neck. Because you're having pain in both shoulders and the shoulder's probably a little bit weak, you're using these muscles to help you a little bit more. So you're starting to develop a little bit of issue in the neck, and that neck problem is causing the nerves to be kind of irritated, and that's what's causing some of the numbness going down. Then I also think you have a trigger thumb.
Yeah. And
So,
also, you talk about the neck. I don't
Yeah.
have a pain at all in the neck.
yeah,
But I have to go real slow when I turn my head.
yeah. So that's the muscles,
Not like
because
now,
again,
or before.
if you can't lift your arm up because of weakness, what do we normally do? Our brain doesn't care how the arm gets from here to here. It just cares that we do it. So you start doing this. You start throwing it up. You start using your accessory muscles, which aren't really designed to, but can help to throw that up. And so now those muscles get tight. And if muscles get tight, they squeeze. And so what comes out of our neck? Nerves come out of our neck, come down through the shoulder and go down. Those muscles are tight. They're probably pinching on the nerves, and that's what's causing the numbness and tingling. So that's where that shoulder pain by itself does not cause anything to go down the elbow. It does not cause numbness and tingling directly. But if it irritates the neck enough, then it can lead to nerve symptoms. So we treat the shoulder, the nerve symptoms go away. So that's what I would do. Now, I don't disagree with you not having surgery on that. I think that that's an appropriate thing, as long as they were still treating you. The problem is when doctors go, and I know people that will do this, they'll say, well, if you don't have surgery, I'm not going to take care of you. Well, that doesn't make a whole lot of sense, So the fact you decide not to have surgery is not a bad thing at all, because again, you weighed it. You said, well, I was still working. Sucks that you can't play tennis, but you're still doing a lot of other things that you probably had to do, and needed to do. And that's appropriate, and if things change and things change for you, then we deal with those symptoms when we need to. The one thing I will say is that 65 years of age, after 65, the rates of healing of rotator cuff repair goes down. Just because we get older, our ability to heal is less and less. So I'm less inclined to do rotator cuff repairs as we get older, because what I don't want to do is have someone go through that 6-month recovery that I said was really long, and at 6 months go, sorry, it didn't work. I mean, that's just the worst thing. And that can happen. And that's why you have to look at the MRIs. You have to do a good exam. There's a lot of things that go into this, and it's becoming more complicated. We want to make sure that we make the right decisions for the right people.
Now, you mentioned nerves.
Yeah.
I'll give you 2 instances. I had a problem with vertigo, a little bit of balance and dizziness. So I went to the specialist that was taking care of the vertigo, but then she wanted me to see a neurologist. So when I seen a neurologist, he gave me this test with like electric shots.
Yeah, the EMG.
Not fun. But it
No.
turns out I have a very slight neuropathy. Okay, which causes every now and then, I'm better at it when I talk to myself. When you're walking, you almost get the feeling like you had a little bit too much to drink type thing.
Sure.
You get okay. Now, because I had the beginning of a neuropathy, so they tell me the beginning, and of course, age related, they always tell you that. Could that have anything to do with I'm just bringing it up because of the nerve factor. Neuropathy,
Maybe, but
why?
neuropathy tends to start at the periphery. So it tends to start at the hands and feet and work its way up.
Okay,
But it
just
can have
curious.
instances though, because if you can't feel your feet as well, you lose that sense of where you are in space, right? And then that can affect balance as well. So that's a huge portion of this as well. Absolutely. What else? Other questions? Okay, go ahead.
I just want to say, first of all, would I be able to make an appointment with you with a whole mess of problems?
Sure.
But, yeah, I had this shoulder problem for
Yeah.
maybe 25 years ago. It started out, and then just lately, last year I had a hip replacement surgery, and I think they put me on this side, which is, I don't know.
Yeah,
I was asleep.
you are laying on your
So-
side during
so
surgery.
it hurts now more after the surgery here.
Yeah.
I can't lift it up here like this one, just
Yeah.
goes straight up.
Yep.
But this, you can't.
So you're
It, like,
weak
breaks
and
them.
right, you're weak and you're stiff right now, right? And so the first thing I would do is get an x-ray to see, is this arthritis or is this stiffness? If it's stiffness, I can stretch you and get that motion back, maybe talk about different things we can do to help with your pain. But if it's arthritis, that we treat that a little bit differently. We do the injections a little bit differently. I have you just do your own activities. I don't necessarily have you do therapy because I don't want to aggravate those symptoms. And then I also have to see, well, are you weak too? So is it arthritis and rotator cuff, or is it one? That's the thing. So yeah, happy to
Yeah, I
help.
have well, I used to play a lot of table tennis and tennis,
Yes,
and I was a tournament player and everything, so and I hit real hard, even table tennis.
sure.
And this here, you know, it would hurt me, this right in here. And
absolutely.
plus, I can't reach as far like this one, I could reach
Yeah.
far. This
And we
one,
talked about, remember the rotator cuff being for reaching activities and overhead activities.
Yeah,
So
I can't, and
absolutely.
then when I go on the wall, I try to put my hand up way high. This one here, I've never reached the height of this one.
Yeah,
You know, I can't, you know, even you with the fingers, I'm crawling.
trying to
up,
work
you
it
know.
up the wall. Yeah. So
So,
yeah, we can definitely try to help you.
So that's what I was,
Yeah, we'll have that information
Yeah.
available. Yes,
From online,
yeah.
what are the recommendations for over-the-counter pain relief when you limit the use of NSAIDs due to management of blood pressure?
Yeah, and blood pressure is one, people who have kidney disease, people that have stomach issues, people that are on anticoagulation. Those are all patients that typically can't do NSAIDs because it interacts with all those medicines. So I typically will recommend Tylenol. I'll recommend some of the topical NSAIDs like diclofenac, Biofreeze. I've also started telling patients to use turmeric, which is a naturally occurring NSAID, which doesn't have that same negative effects. So I usually do those things. I typically tend to be more aggressive on doing the injections in those patients because they can't do NSAIDs. But ice, Tylenol, topicals, turmeric, and then injections is usually what I do. But that's actually a great question. What else? Yes.
I have a lot of pain in my trapeze.
Mm-hmm. Mm-hmm.
And years ago, when I was working on a farm, I fell between two bales of hay face down, and the kid up who we were wrestling, he fell right smack in the middle and hurt. And then everything was good until I was about 40, then I had constant pain across my hips. I'd see a neurosurgeon, and he'd say, "How did you do that? Did you walk in here?" No, that kind of thing. But so I see a naturopath. But I wake up in the morning with this finger stuck. And I
You have a trigger finger too. You guys should go together.
I got the phone, he's got the
He
finger.
does.
Is
Yeah.
that caused from this or?
It's completely separate. It's a very common problem where the tendon sheath gets like kind of scarred in and gets caught. And so you have to, you know, we usually tell people soak it in warm water and massage it. Usually the problem is here, right at the base here. It's not up, even though you get stuck here, the problem is here. So we usually will tell people to kind of put it in warm or hot water and massage it to try to break up the scar tissue that's causing the tendon to get stuck. If that doesn't work, a hand surgeon can do a small injection to kind of relieve it. If that doesn't work, they do a small little surgery called a trigger finger release. That's like less surgery than like a carpal tunnel. It takes like 5 minutes, but it gets rid of the problem for people. But yeah,
I got like a knot right here.
that's where it is. That's where the problem is.
And this
So
is-
massage that out, warm water, that's the first line. If that doesn't work, then usually we do an injection. And in minority of patients where that doesn't work, then the hand surgeons will sometimes do a small surgery. Yes.
My shoulder pain is not really a big deal during normal activities. However, it was right, like you have the one slide at night.
Yes.
I sleep on one side on my shoulder, and then 45 minutes later, it's hurt.
Yeah.
Roll over, sleep on the other one, and sleep for 45 minutes, and then that one starts hurting. So
Yeah.
It's back and forth. And I just went to my primary care physician a couple days ago for my Medicare wellness.
Mhm.
And he referred me to get an X-ray. I have not had it done yet, but what does it show and what does it not show as far as X-ray or is X-ray the route to go?
The X-ray, really, the only thing I'm looking for you for that would be, do you have any arthritis? Okay, I would guess not based on what you're telling me, because arthritis typically gets aggravated the more you use it, okay? Pain is primarily at night is usually a phenomenon in which people lack mobility rotating down, okay? For whatever reason, the sleeping issue tends to be a loss of, we call internal rotation, which is kind of reaching behind their back. So usually what I end up doing is, it's usually a combination of bursitis. So again, go back to where we started from. First step, get rid of the pain. But if you're not having much pain during the day, I wouldn't be too aggressive with that, but I would give you some design stretches to work on this mobility. Because the problem is when you sleep on your side, your arm has to go somewhere. And if you don't have the mobility to put it where you're normally used to, you're never going to be comfortable. And it usually is a lack of rotation in the shoulder, usually down. that causes it. And what we've seen is that as your internal rotation gets better, your sleeping gets better. So that's usually what it's from.
And I have had both hips replaced about 10 years ago.
Mhm.
Hers is new.
Yeah, yep.
There's no problem.
Yeah.
So
Hip-
My
hip
knees are good too.
Hip replacement is probably the best and easiest in terms of all the joint replacements. Knee is the hardest, shoulder is somewhere kind of in the middle. So,
Yeah, I was shocked when I got the first hip and they
Yeah.
had me in the stairwell an hour later. with
Yep.
a therapist with a belt around my waist, but I was doing the stairway,
yeah,
after getting off the table an hour before.
yep. And we're aggressive with it now.
She wanted to
ahead.
go first. so-
Yeah. Go ahead.
Yeah, go
Yeah, I just had a question sort of about that moon study, because
Yeah.
what, 85% of people
Yeah,
are successful, is that
Yes.
long term?
5 years right now.
I'm
5
sorry?
years, at 5 years.
Oh, okay.
In 5 years.
Because I had a rotator injury about 30 years ago,
Mhm.
and they did therapy, which
Mhm.
lasted about 20 years.
Mhm.
And then something happened and I had to go to therapy again, and it's progressively getting shorter and shorter. So it was 20 years, 5
Yeah.
years, 2 years, and now I'm back.
The problem is that the natural history of rotator cuff tears is they're either gonna stay the same or get bigger over time. They're not gonna heal, full thickness tears do not heal, okay? Now, can I tell you when it's gonna get bigger? We don't know that. It could get bigger in a month, a year, 10 years, or never. So we can't, that's why we never do rotator cuff surgery prophylactically to prevent it from getting bigger, because we're not gonna do surgery for something that might happen. That doesn't happen. And so it's unfortunate that the timeframes are getting shorter, but as long as it's still working, I think it's still worth it to do, unless you get to the point where the treatment's only lasting you weeks, then that's no good, because again, we risk, if you're doing injections, you risk weakening the rotator cuff, which is not a good thing. But as long as your motion and strength are good and the treatments are effective, I think it's still worth doing. And unfortunately, when you initially got treated, 20 years ago or whenever you were 20 years younger, you do better than we do right now. That's just unfortunately what happens, and so the treatments don't work as well. As we get older, we tend to get stiff and we tend to get weak. My mentor used to say, as we get older, the reason we exercise is that normal things don't hurt anymore. It's just kind of what happens, and so we have to stay on it. So it just becomes a little bit harder as things go on. So.
And one more question,
Please.
turmeric. So how much turmeric, do you buy a capsule, or do people just take it, what's the turmeric, golden juice? Golden
Yes.
milk or something?
Yes, there's no dose response we know of right now with it. So the answer unfortunately is yes, just like, people have been told to take glucosamine chondroitin for arthritis in their knees and hips. We don't know a dose yet, but we know that it's safe, it's inexpensive, it doesn't interact with anything, and it does help some patients without hurting anyone. So, but yeah, we don't have a dose response yet on that. So no, unfortunately. Go
I
ahead.
just want to bring one of the x-rays.
Yes.
I had my shoulder, they took an x-ray, didn't find anything. I just couldn't stand for that. I got pain, there's something wrong. with me.
Yeah.
To find it, I had to get an MRI.
Mhm.
But at first I would let it go, no big deal. It's a big deal, my arm hurts.
Yeah.
So then they gave me the MRI, I want to bring it up to you. They couldn't find anything with the x-ray.
Mhm.
But they did find with the MRI, that was in about 45 minutes, and
Mhm.
things on your head and all this stuff. But they had to use the MRI to find it, and the x-ray didn't show it.
So a couple things, an x-ray is not going to show a rotator cuff tear. It's just going to show the bones. First thing I noticed is that the x-rays that are typically taken at either an ER or in some primary offices are not the right x-rays. They don't show what we needed to show. So unfortunately, I ended up having to repeat, because they get 4 views, but they get the same view 4 times, which doesn't help us, Again, although an MRI is going to give us more information, I would bet if they did they examine you?
They probably did, it was so long.
Yeah,
I just wouldn't go along with the fact that we can't find anything. I'm saying there's something wrong. I can't.
Yeah, no, I don't disagree with that, but my problem with that is that unfortunately in this day and age, and this is a doctor problem, not a patient problem, we're doing more and more MRIs, we're doing less and less examinations, and that's a huge problem. So instead of taking the 5 minutes to do a good exam and probably diagnose you appropriately, they walked in and says, oh, you're not better, here's an MRI, and they walk out and you're in there for 20 seconds. I mean, and that's never the kind of medicine. So, yeah. But it's unfortunate that I've seen that where, multiple people get MRIs and I examine them, they're like, Dr. Leonard, it's the first time who's ever examined my shoulder. And I find that to be just crazy because there's a lot you can get from that. So Now, sometimes we don't know and we need the MRI, so that's not against it, but again, it should be more of a surgical planning tool, not necessarily well, we don't know what to do. Now, that does happen on occasion, but that's kind of what I've seen. So what else? Yes.
I'm in my early 90s, and about 3 months ago, I had a lot of trouble moving my arm away from my side.
Yeah.
I went and had an X-ray. Oh, it's arthritis, but you better go see an orthopedic. Unfortunately, it wasn't your group.
It's okay.
I went to the orthopedic people,
Uh-huh.
and they gave me a shot and said, go for 4 weeks of therapy.
Yeah.
Which did no good at all.
Right.
No progress. And my second shot and said that we either gonna have to learn to live with it
Mhm.
or have maybe an operation.
Yeah.
And in July, I supposedly can have my third shot,
Mhm.
but I still have trouble.
So,
So they didn't suggest any more therapy. I don't know whether I should be doing, the MRI said 2 slight tears, bursitis and arthritis.
yeah, so a couple things, if they said slight tears in your age group, that means your rotator cuff is doing pretty good. So I think rotator cuff is out, I'd be focused more on the arthritis. The first thing I would look at is where are they doing the injection? Because there's no such thing as a shoulder injection, because the shoulder is a complex joint. Was it in the bursa? Was it in the joint? Was it in the AC joint? Was it in the biceps? So not all injections are created equal. If I put an injection into the bursa and you have arthritis, yeah, you're not going to get better, but that's my fault for putting it in the wrong spot. So they keep repeating the injection into the wrong spot every time. They're not going to get it. Now, in some cases, the reason we have surgery is because in some cases, it truly just isn't going to work. But for someone with new onset pain that hasn't been going on, I would be suspicious of where the injection was given, number one. And if it truly didn't work, then, there's other treatments. We're starting to use gel injections now as opposed to cortisone, just like knees and hips, we're using gel injections. There's other types of medicines and injections we're using. I would, again, hold off on the therapy because, again, I think therapy just aggravates arthritis. I don't really think it helps. So I'm not against stopping therapy if it wasn't helping you early on, because it may just be aggravating it. And I would try to get a little bit more creative in terms of where to do the injections and what else that could be done that way.
Thank you.
What
Just a
else?
real quick one on this.
Please.
Maybe 15 years ago, I went to a chiropractor
Mhm.
and had some treatments. I think it was about 7 of them, and didn't quite help.
Yeah.
He put the electrical thing on here and shot thing or whatever. It felt nice, but I don't know. It's
I
same
think
way, like,
my brief opinion on chiropractors is that chiropractors are great for acute muscle injuries. They treat muscle acute pain. So if I have an athlete or someone that got injured, their muscles are sore, then I think the chiropractor will help with that immediate initial pain. They can't take care of anything chronic. Okay, they can't adjust anything. They're not going to correct any long-term issues. They are not going to correct any imbalances. Everybody everyone needs an adjustment or things along those lines, but that's not going to help. That will help with the pain initially in terms of relaxing the muscles, but it's not going to have any long-term benefit. So I think short-term, I think they do a great job. I think if they want more than 5 sessions, I think you should turn around and go the other way, because that's where I think they it's a little bit outside of their scope. That's my opinion on
I
that.
did like about 7 of them.
So, yeah, so I think after 5, if it's not helping, then this is more than just like an acute muscle injury. You strain a muscle when you're doing something, you bend over, your back muscle spasm. Chiropractor is great for getting that better, a couple sessions, get the muscles relaxed, get you back. But if it's something that's more, they're not going to be as effective with that. So, yes.
When I kneel on this knee for 2 minutes or less,
Mhm.
I can hardly walk for 2 weeks.
Mhm.
And I have it right now. The only thing I was taking was ibuprofen, and I read that there's warnings and I don't want to take it.
Sure. Yeah. I think, again, when we talk about like NSAIDs, this is designed to be a short course of NSAIDs. This is not meant to be a lifelong issue, because we just talked about people that can't take NSAIDs. Kidney issues, stomach issues, problems with hypertension. So it's meant to be a short-term, problem. Like Tylenol is much safer to take long-term. than NSAIDs would be. I'm nervous about giving NSAIDs to anyone older than 75, because that's when our kidneys are a little bit more sensitive to those kinds of medicines. So I'm very careful about who gets NSAIDs over 75. But it sounds like you have some arthritis underneath your kneecap, so you don't have that cushioning. So when you put weight on it, instead of the cartilage cushioning things, you're kind of going a little bit bone on bone. And that's where cortisone, gel injections, things along those lines can sometimes help. And if those don't help, who had good hips and knees? Who has good hips and knees? So there's, so we have someone who did well with a hip and a knee replacement, so.
Yeah, I would be 89, so
So.
I'm still working, but
Yeah,
I gotta have them knees working.
no, that's fair. What else?
Before I got my hip, so I had steroid injections.
Yeah.
And they shot that in, and I got off the table, I felt like I was 20-year-old.
Yeah.
And it lasted for about a week.
Yeah, that's.
And then I did a microscopic surgery too, and that one didn't do anything. I had 3 different surgeons tell me it's bone on bone, it's really.
Yeah, I mean, hip arthroscopy, similar to shoulder arthroscopy, is like, it's good for soft tissue problems. When we start getting down to arthritis, the minimally invasive stuff just isn't as good. It just, we think minimally invasive is much better. For certain things it is. But when we start talking about, loss of cartilage, that's the one thing we really haven't been able to really advance as an orthopedic, group, is how to help with those degenerative conditions, how to prevent that from getting worse, and how to treat that better. They're doing things with platelet-rich plasma and gels and all these other new, stem cells. Everyone hears about stem cells, but none of that stuff has been proven. So everyone hears a commercial about here's the latest and greatest. But what they don't tell you is when you get there, well, first of all, insurance won't cover it. It's cash only. Well, why is it? Because it's not proven. Not proven. There's no science to support it yet. Cortisone has science, but even the gels that we give, the science isn't great. Everything else is giving the money and flipping a coin and hoping it works. But there's no science to prove that any of that stuff works yet. It doesn't mean it won't work or that the science hasn't shown it to work yet. But right now, we can't say that it's been shown to work yet, unfortunately.
I tell this to a lot of people because my surgeon at Midwest Orthopedics, after I got my new hips, he put his finger right on my face. He said 2 things. 1, do not put on weight. And 2, stay active.
I
Do
probably
something.
know who your surgeon is, so.
Good advice.
So, yeah, what else? Other questions?
Oh, just one, you said you do, this gentleman had a thumb problem?
Mhm.
Yeah, I do too. It's like got bigger over here, and it's like I can't squeeze with, it's a good thing in my right hand. I'm right-handed, and it's like, why did my left hand start having a problem? I don't get that.
Yeah, it doesn't tend, most of these things don't tend to be dominant related. It's weird,
Oh.
like rotator cuff, arthritis, people think, oh, it's not my dominant arm. It doesn't tend to be a correlation at all with it. So it's your dominant arm. Yeah, you use it more, but it's also probably a little bit stronger, so it could probably handle it a little bit better. But for people who've injured their non-dominant arms, they realize how much they actually use their non-dominant arm when they can't use it for a certain period of time. So
Yeah, it's possible.
I'm going to tell my hand surgeon that I think that I got her more patients here than I got the hand surgeon, the knee. So yes,
The longer you wait, the bad results that happen.
good question. So, the adage, you use it or you lose it, right? So if the muscle is torn off the bone, you can't work it out because it's not moving when you move the arm. If you don't use a muscle, it turns into fat. If you have muscle that's all fat, it will not heal. And that means, so it negates the ability to repair it. That now, again, it takes about 2.5 years for a muscle to atrophy to the point that it can't be fixed. So you have to be really having a lot of dysfunction for at least 2.5 years for that to happen. But yes, the minute that muscle starts becoming torn off the bone, it's going to start to degenerate into fat. And so, if I see patients who've had rotator cuff tears for 10 or 15 years, I'm less likely to offer them a repair because again, I can sew anything back to the bone, but if I know it's not going to heal, I don't want them in 6 months realizing, oh, this didn't work. So there is something to that. Now, everyone's a little bit different. This is an average, but when it comes to rotator cuff tears, yes, time is of the essence, but it's not like, this is an emergency. And that's why we give rotator cuff tears 6 to 12 weeks of therapy, because that's still a short enough time window to where if it doesn't work, we didn't lose anything by then operating on them. And even 6 months is okay, but around a year, start getting into 2 years, that's when that muscle starts to become almost, we can't get it back.
Because in my Indian community, it is always advised, don't go for surgery, do not go for surgery. They wait for almost like when they cannot even do anything.
Yeah.
How?
And I get, again, although it's, I don't want to recommend surgery for people. I really don't. I recommend it as a last resort for people that really need it. And it's a wonderful operation. But, again, any surgery has risks. We want to make sure that when we're doing it, the benefit of surgery far outweighs any sort of risk to it. But if someone has had therapy, has had injections, is still having pain, is still having weakness, can't work or can't do the things that they want, all those things are telling me that this person needs a surgery because they're really struggling without it, then it makes sense. Waiting is just gonna, now we're talking about doing replacement surgery, and bigger surgery when it's really not necessary. So, but everyone's a little bit different. I mean, I saw a patient today in clinic who has a rotator cuff tear, but he has to work or, for his family. And I get it, and we watch it and we're careful with it. And I tell him, I'm like, look, there's risks associated with this, and he gets it, but that's his decision and that's okay. That's his choice. No one ever has to have shoulder surgery, but there's risk associated with waiting. But at this point, this is the right thing for him to do in his life. I treat the shoulder, but I have to treat the whole person first.
So this is the last question.
It's okay.
Right. So, now that you have all these things, is the people coming earlier than before? Like we are already 70, 75, and we are developing all these things. So are we started taking advantage of all these nice things you have and living longer because of your progress in joint?
Well, I think the answer to that is yes, because again, the data shows that shoulder arthroplasty is skyrocketing. The amount of people getting this. There is a large group of patients between the ages of 65 and 85 where there was no option for them. They were going to have to live with their arm like this. And now they can get a replacement and be able to lift their arm like this. We're able to do rotator cuff surgery better and get good results. We're able to, but some of this information is telling us that, we can treat this without surgery, and patients that are nervous about surgery now may be more comfortable to come in and be treated without surgery, whereas before they say, well, no, if I go, I'm going to need surgery and I don't want that. So I think as we just, again, continue to accumulate knowledge on things and then bring it out to the community so that they know what's real and what's not, again, it's interesting. I always tell patients is that, when you talk about shoulder replacements, the person who's had the bad shoulder replacement is going to tell everybody how horrible it was. But the people who had the good replacement, you wouldn't even know they had the shoulder replacement. They're living their life and you wouldn't even have asked them, how's your shoulder doing? Because you didn't even know they had it. And so I think that's the thing. And so I think as word gets out and, again, this is our job as physicians in the community to spread the word and teach and educate that, it's not the end of the world. The surgery isn't that bad. There's a lot of great chances to get better. I think that helps everybody.
Like my friend 85 and they waited till 85. I said, you should have done this long time.
Well, what I tell patients and the most common thing I get, especially after shoulder replacement, is I wish I didn't wait this long. What I tell them is that you weren't ready till you were ready. If you try to rush someone into surgery and they're uncertain about it, if anything goes awry and they were already unsure of why they were doing this, they're going to be a disaster. They're not going to do well. But if they go in fully committed and says, I'm ready to do this, they're going to do better. And so, yes, they shouldn't have waited, but they weren't ready, and then ultimately that's the most important thing. They got to be ready.
Okay, so don't push it.
Dr. Leonard said you need to have surgery now, but no, I didn't say that. So, what else?
You taking new patients?
I always take new patients. Absolutely.
I want to get your card.
So, yeah, sure. Happy to do it.
So I'm here because I think I have repetitive motion problems.
from computers.
Sure.
Especially, I'm sort of addicted to a certain computer game, which I sort of stopped using now because I have a lot of stiffness. Actually, I used to feel something here in my, down here, but that went away and now I kind of.
Yeah, so I mean, again, people can get, tennis elbow, they can get carpal tunnel. Unfortunately, we start talking about kind of, in front, most of what we do either in front of a computer or in front of a phone, we're always like this, right?
Yes.
We're always like this, which is
Well, that's
horrible.
something I-
We need to back here. So,
Yeah.
but just, repetitive nature, not moving the arm as much. Again, repetitive things typically tend not to be surgical things. They be, okay, let's maximize the motion. Let's get the strength back. Let's do whatever we can for
And
inflammation.
also
So-
stop the activity that.
Correct, right. Or find a way that's more ergonomic, a way where we can do the activity without aggravate the
Without
issue.
support.
Correct.
Yeah,
Yeah.
I've noticed that's been, and the other thing is there, I'm a side sleeper too, now this is causing issues. Is there a good way to put your arms? I mean, is there a recommended way?
There's not, unfortunately, because anytime you're, for most patients, if you're a side sleeper, if you lay on it, it's a problem. If you lay on the opposite side, your arm is draped over, that's a problem. Some people tend to stack pillows and have their arm up like this. That seems to have worked. So sometimes that helps keeping it abducted and away from your body. Because when the arm is down, the weight of the arm is kind of pulling on the rotator cuff. And so having the arm up like this actually sometimes relieves rotator cuff pain. So finding a way to keep your arm up here is sometimes helpful because it takes the weight of the arm out of the equation.
And then still doesn't put stress.
Correct.
Yeah.
Exactly. Yes.
I am a patient of yours. You helped me with my broken arm. And I went in, and you helped me, I have scoliosis, you helped me with the hips. Well, now I have knees.
Mhm.
And I don't know if it's arthritis, but I'm doing exercises.
Good.
And I have an appointment with you. I don't know, so we'll talk.
Yeah, most joints in the body, it's maximizing mobility, maximizing strength, because that actually helps to kind of cushion the joint. There's nothing worse than a stiff, weak joint. That just puts all the stress on the cartilage. And so, although we're talking about the shoulder, a lot of these themes actually go into, strategies for every joint in the body, keeping inflammation down, keeping mobility and strength up to support the joint. And in the knees, although I said rotator cuff disease is more common, in the shoulder, knee osteoarthritis is the most common in the knee, most common cause of pain. There's no doubt.
So you just said a key word, inflammation. And what most people don't know is SUGAR.
Oh, yeah.
Oh, yeah.
It adds to your inflammation. And so what I've been doing is using honey, cane sugar, and maple syrup for my sugar.
Mhm.
But the inflammation, and you said Tylenol for inflammation. Is
Well,
there anything else?
Tylenol is really for more so pain. It's not really for inflammation, but it's there for pain. But there's a lot of things too, in terms of that, in terms of things like gluten, in terms of sugar, in terms of, a lot of these toxins that we take in that lead to just generalized over, inflammation in general. But it's the tried and true is, ice to the area, getting rid of inflammation, keeping motion and strength up. Those are kind of the backbones by how most of these things are treated. So,
Thank you.
Thank you very much.
all right, thank you, everybody.
Thank you a lot.